Have you ever really stopped to think about your personal risk for something serious, like, say, heart disease? Maybe you're young, you feel pretty healthy, the usual things to watch: cholesterol, blood pressure, maybe smoking or diabetes run in the family. But what if there's this significant piece of the puzzle that often gets missed, especially earlier in life? Something that could be affecting your risk right now.
That's a really crucial question. And it's exactly what we're digging into today. We're doing a deep dive into some pretty substantial new research. It focuses on this specific particle in your blood called lipoprotein A, or LTA for short.
LPA, okay.
Yeah, and this research looks specifically at its link, a significant one, to heart disease happening prematurely, so, generally before age 65.
And this isn't just like one small study, right? You said substantial.
No, not at all. The
Yeah.
source material we're looking at today is a huge systematic review and meta-analysis. It just got accepted in March 2024, published online ahead of print in April 2024 in the European Heart Journal Open.
Okay, so very recent.
Very recent. And what makes it powerful is it pulled together data from 51 different studies. We're talking over 100,000 participants involved.
Wow, over 100,000. That's a massive amount of data to tackle this question.
Exactly. And that scale is key. A meta-analysis like this, it can often give us a much clearer picture, a more definitive answer than just looking at single studies, especially when, maybe previous research seemed a bit mixed on the topic.
Right, it helps cut through some of the noise. So our mission today is to really unpack what this huge data set tells us. We want to understand the role of elevated LPA in premature atherosclerotic cardiovascular disease, ASCVD, and why it matters, especially for younger folks listening.
Yeah, it's about understanding a risk factor you might not have even heard of before.
Absolutely. So let's start with the basics then. What is this LPA?
Okay, so based on how this review describes it, you can think of LPA as being pretty similar to LDL cholesterol, the bad cholesterol everyone talks about.
Right.
But LPA has this extra bit sort of stuck onto it. It's a protein called apolipoprotein, or APOA. It's chemically bound, covalently bound, to the main protein part of the LDL-like particle.
Okay, so like LDL's more complex cousin, maybe a bit more troublesome?
That's a good way to put it. And the study highlights something really crucial about where your LPA levels actually come from.
Which is?
Well, it emphasizes that your LPA level is largely set by your genetics. We're talking about 90% inherited.
90%? Wow.
Yeah, it's mostly determined by variations in just one gene, the LPA gene. So unlike your standard LDL cholesterol, which diet and lifestyle can heavily influence.
Right, you can work on that one.
Exactly. Your LPA level is something you're pretty much born with. It stays relatively stable throughout your adult life.
That is a fundamental difference. Okay, so if it's mostly genetic, how does it actually cause problems? How does it hurt your arteries?
So the paper goes into the proposed ways it does damage.
Yeah.
LPA is known to be a major carrier of something called oxidized phospholipids, basically damaged fats that are pro-inflammatory. Not good. But beyond just carrying those, LPA itself seems to actively promote plaque development that build up in your arteries.
How does it do that?
Through several pathways, really. It's pro-inflammatory, so it encourages inflammation in the artery walls. It's pro-thrombotic, meaning it makes blood clots more likely to form on top of any plaque. And it's also antifibrinolytic.
Antifibrinolytic, meaning?
Meaning it makes it harder for your body to naturally break down those clots once they form. So all these things together can really speed up the process of atherosclerosis, the hardening and narrowing of the arteries.
Got it. So genetically determined, carries inflammatory stuff, encourages clots, and stops clots from breaking down. Sounds like a triple threat for your arteries.
It really does seem to work on multiple fronts.
Okay, now the other key term here is premature ASCVD. What conditions are we actually talking about in this study?
Right, ASCVD stands for atherosclerotic cardiovascular disease. That's the umbrella term for conditions caused by that plaque buildup. So it includes things like coronary artery disease, or CAD, that's what leads to heart attacks. Also stroke and peripheral artery disease, PAD, which affects circulation, usually in the legs.
Okay. And premature in this context usually means?
For this meta-analysis, premature generally meant these events happening before age 65. Though they did mention some of the included studies used slightly younger cutoffs, like under 50 or under 60.
So we're really focusing on heart attacks, strokes, serious circulation issues hitting relatively young, years, maybe decades, before they might typically show up. And you mentioned before this big review, the role of LPA in younger people wasn't totally clear.
Exactly. It was pretty well established that LPA was a risk factor for ASCVD in older adults. But for younger populations, the evidence was a bit, well, less consistent. Some studies showed a link, others didn't find a strong one. This meta-analysis aimed to pull it all together specifically for that younger group to get a clearer answer.
All right, makes sense. So let's get to it. The main finding. After crunching data from over 100,000 people, what's the bottom line? What's the big takeaway about high LPA and these early heart problems?
The big takeaway, the core finding, it's really clear and frankly quite impactful. Elevated LPA is significantly associated with a higher risk of having one of these premature ASCVD events.
How much higher?
When they looked at the combined risk, what they call composite ASCVD, grouping all those events together across several key studies, they found having elevated LPA, well, it basically more than doubles your risk.
More than doubles the risk of a heart attack, stroke, or PAD before 65. That's huge.
It really is. The specific number they calculated was an odds ratio of 2.15, and the stats showed this was highly significant. Very unlikely to be just a fluke or random chance.
Okay, wow. And was that just for the combined events, or did it hold up for individual problems too?
It held up strongly. Even when they analyzed the individual types of ASCVD events across almost all the studies, 49 of them, the signal was still there. Having higher LPA, looked at categorically like high versus low, was linked to roughly 2.35 times higher odds of any single premature ASCVD event.
So it's not just one or two studies driving this result. It's a consistent pattern across the board.
Precisely. And the link was there whether they treated LPA as a category or as a continuous thing where, the higher your LPA, the higher the risk appeared to be.
Okay, that's a strong overall message. Now let's break it down a bit more. Did high LPA seem to have a stronger connection with certain specific conditions like heart attacks versus strokes?
Yes, they did drill down into that. And the links were particularly strong for some conditions. Elevated LPA showed a really robust association with premature coronary artery disease, so heart attacks and related issues. The odds ratio there was 2.44.
Nearly 2.5 times the risk for early heart attacks.
Exactly. And it also showed a strong link with premature peripheral artery disease, PED, those circulation problems in the limbs. The odds ratio there was 2.56.
So again, over 2.5 times the risk. High LPA seems especially bad news for early heart attacks and leg circulation problems. What about stroke?
Now that was an interesting finding, a bit more nuanced. While the link was strong for CAD and PA, this meta-analysis did not find a statistically significant association with stroke overall in these younger individuals.
Okay. Why might that be?
Well, the link looked weaker, and the authors speculated a bit. They suggested that maybe LPA's main effect, being pro-atherosclerotic, building plaque, might primarily drive the risk for only certain types of stroke. Specifically, strokes caused by plaque buildup in the large arteries feeding the brain.
Ah, okay.
Yeah, they referenced some earlier research suggesting that link, rather than LPA necessarily increasing risk for all types of stroke, equally in younger people.
That makes sense, actually, given its mechanism is so tied to plaque, so strongly linked to the plaque diseases. Now, were there certain groups of people where this link between high LPA and early ASCVD was even stronger?
Absolutely. And this is really important for figuring out who might be most vulnerable. The association was significantly stronger in a few specific patient populations. For people who already have familial hypercholesterolemia, FH.
That's the inherited high cholesterol condition, right?
It's a very high LDL from birth. For those patients, having high LPA on top of that meant an odds ratio of 3.11 for premature ASCVD.
Wow, so over 3 times the risk, adding on to the risk they already carry from FH.
Yeah, it seems to layer on a substantial amount of extra risk. The association was also significantly stronger in patients with type 2 diabetes mellitus, T2DM. The odds ratio there was 2.23.
Okay, so if you have FH or type 2 diabetes, knowing your LPA seems even more critical for understanding your early heart risk. What about differences across race or ethnicity? Did they look at that?
They did analyze by race, and yeah, they found some variations. A very strong association popped up in South Asians. The odds ratio there was 3.71.
And nearly 4 times the risk for South Asians.
Yes, a very strong link. And also strong in Caucasians, with an odds ratio of 3.17.
Okay.
However, interestingly, they did not find a statistically significant association in the Chinese populations included in the analysis. The authors did add a note of caution there, though, mentioning limitations around the number of studies and how age was grouped in those specific subgroups, suggesting more research is needed.
Right.
But certainly for South Asians and Caucasians in this large data set, the link between high LPA and premature ASCVD was clear and very strong.
That's a pretty striking difference. It suggests the risk isn't necessarily uniform across everyone. Now, here's something I feel is really key for prevention. How did high LPA interact with levels of standard LDL cholesterol, the regular bad cholesterol?
Yeah, this I think is one of the most interesting and potentially actionable findings from the whole analysis. What they found was the association between elevated LPA and premature ASCVD was really only statistically significant when baseline LDL cholesterol was also somewhat elevated.
Oh, really? So they work together?
It seems that way. Specifically, the link was significant when baseline LDL was 2.6 millimoles per liter or higher. That's about 100 milligrams per deciliter in U.S. units.
Okay, 100 milli-GDL, a common threshold people talk about.
Exactly. And the risk didn't just appear at that level. It actually increased substantially at even higher LDL levels. So it looks like having both high LPA and high standard LDL is a particularly bad combination.
Why would that be? Do they have ideas about the mechanism?
They did offer a potential explanation. They discussed how LPA particles are partly cleared from our bloodstream by the same receptors that clear LDL cholesterol, the LDL receptors on cells.
Okay.
So the theory is when your LDL cholesterol levels are high, those receptors might be kind of, well, busy or saturated dealing with all the LDL.
Right, they're already working hard.
Yeah. And that might make them less available to clear LPA effectively. So the LPA could hang around longer in your blood, potentially exerting its harmful effects more readily.
Ah, okay. So high LDL might actually hinder the body's ability to get rid of the high LPA, making the LPA risk even worse.
That makes sense. And did this interaction have a flip side? What if LDL was low?
Yes, that's the crucial other side of the coin. The association between elevated LPA and premature ASCVD was not found to be statistically significant when baseline LDL was below that 2.6 millimole or 100 mg/dL threshold.
Interesting. So even if your LPA is high, if your LDL is low, the risk might be lessened.
That's what this data suggests. While the odds ratio still looked a bit elevated in that subgroup, the finding wasn't statistically robust. It implies that maybe when LDL receptors aren't so busy because LDL levels are low, they might be better at clearing LPA, even if the LPA level itself is genetically high. This could potentially reduce its harmful biological impact, at least in terms of premature disease. That is a really important insight. It really suggests that for someone who knows they have high LPA, being super aggressive about managing their standard LDL cholesterol, maybe aiming for really low levels, could be particularly protective against these early heart problems.
It certainly points towards that potential synergy, yes.
Yeah.
It gives a clear picture of who with high LPA might be most vulnerable to early events specifically, those who also have higher LDL. It provides a kind of reference point for prevention strategies in younger people.
Yeah, a target.
Right.
And the study also found this LPA link held up across different types of studies for both men and women, different settings, different age cutoffs for premature.
Yes, the overall significant association was pretty consistent across those different variables, adding weight to the findings.
Did they look at specific LPA levels? Like, are there certain cutoff numbers that seem especially risky?
They did. They looked at common clinical cutoffs used to define elevated LPA. They found a significant association with increased premature risk using thresholds like 30 milligrams per deciliter, which is about 72 nanomoles per liter in other units, and also at 50 milligrams per deciliter, which is around 110 nanomoles per liter.
And what was the risk increase at those levels?
At the 30 milli-GDL mark, the risk was roughly doubled compared to lower levels. At the 50 milli-GDL mark, it was nearly tripled.
So those numbers doctors often use as thresholds, they seem to directly map onto significantly higher risk for early events, according to this huge analysis.
They do appear to be clinically relevant thresholds based on this data. Now, there was one slightly odd finding related to levels.
Oh.
When they looked specifically at the very highest LPA levels, categorizing people into fifths or quintiles, and looking at the top fifth, the association in that specific subgroup analysis didn't reach statistical significance.
Huh. So super high LPA isn't risky. That seems counterintuitive.
Well, the study authors were careful to point that out. They noted that that specific analysis looking at the top quintile only included data from a very small number of the studies, just 4 out of the 51.
Ah, okay. So maybe not enough data points in that specific slice.
Exactly. They basically said that finding was less reliable than the overall results, or the results based on the 30 and 50 milli-GL cutoffs, which used data from many more studies. So we definitely shouldn't interpret it as meaning extremely high LPA isn't risky. It's more that the data was just a bit thin in that particular analysis to confirm the link robustly there, whereas the link was very clear at those commonly used clinical thresholds.
Got it. That's a good reminder about looking at the details. Even in a big meta-analysis, you need enough data for each specific question. So, okay, let's pull all this together. Why does this really detailed research matter for, for you listening right now, maybe a younger adult thinking about long-term health?
Well, it matters because this research strongly backs up the idea that high LPA, which remember is mostly genetic, isn't just some minor lab value. It's a significant independent risk factor for serious heart problems happening years, maybe decades, earlier than you might expect.
Especially if you fall into one of those higher risk groups.
Exactly. Especially if you also have FH or type 2 diabetes, or if you're South Asian or Caucasian, according to this data. Or, and this seems key, if your standard LDL cholesterol is also on the higher side. It's a risk you're essentially born with, but knowing about it helps you understand your overall picture better.
Right. It flags you as someone potentially starting with a higher baseline risk, baked in from day one. What are the clinical implications then? What does the source say doctors might do with this information?
The discussion in the source really emphasizes that LPA testing is already recommended by some major clinical guidelines, often just once in a person's lifetime, because it doesn't change much.
Okay, so some guidelines already say check it once.
Yes, and these findings really reinforce why that testing is important, especially for younger people. If you identify elevated LPA early, particularly in those vulnerable groups we talked about, it could trigger earlier, more personalized risk assessment.
So if your LPA comes back high, it tells your doctor, okay, this person might be at higher risk for early problems, even if their other numbers look pretty good right now.
Precisely. It adds a layer to the risk calculation. And the source even suggests that knowing about high LPA might lead doctors to consider more definitive tests earlier, things like advanced heart imaging, maybe even invasive tests in some cases for young patients, even if they don't have classic conditions like FH or diabetes yet. It could change how aggressively potential issues are investigated.
That makes a lot of sense. If it's a lifelong risk factor, knowing early allows for earlier, more targeted monitoring and prevention. What about actually managing high LPA? Can you just, take a pill to lower it like you do for LDL?
Yeah, the source tackles that directly. And the reality is significantly lowering LPA with the standard therapies we have readily available right now is challenging.
Okay.
Things like statins, which are absolutely critical for lowering LDL cholesterol and overall cardiovascular risk, generally only have a modest, if any, effect on LPA itself. Some might slightly raise it, some slightly lower it, but it's not their main job.
So statins don't really fix the LPA number directly?
Not really. However, the paper does mention some approaches. PCSK9 inhibitors, another class of cholesterol-lowering drugs, can lower LPA levels maybe by about 20–30%.
Okay, that's something.
It is. And there's also lipoprotein apheresis. That's a procedure kind of like dialysis where they physically filter particles out of your blood. That can lower LPA much more substantially, but it's usually reserved for very specific high-risk situations.
Right, not something everyone would do. Are there new treatments coming?
The source does mention that, yes. Novel therapies, like RNA-targeting drugs specifically designed to shut down LPA production, are in development and showing quite a bit of promise in lowering LPA dramatically in early trials, but they aren't widely available yet.
Okay, so direct lowering is tricky for most people right now, but maybe things are on the horizon. So what's the main message for managing risk if you do have high LPA?
Here's the really critical point the source emphasizes. Even though LPA itself is hard to lower directly with current standard tools, aggressively managing all your other modifiable risk factors is paramount. And top of that list, lowering elevated LDL cholesterol.
Because of that synergy. Because high LDL seems to make high LPA worse.
Exactly. The study strongly suggests that since high LDL seems to amplify the harmful effects of LPA, getting that LDL number down, often using statins, can significantly mitigate the combined risk, even if the LPA number itself stays high.
Okay, so the strategy is know your LPA, but focus hard on controlling everything else you can control, especially LDL.
That's the key takeaway for management right now, yes. Plus, of course, all the standard lifestyle advice, diet, exercise, not smoking, remains crucial for overall heart health, regardless of your LPA. Knowing you have high LPA just makes managing those other factors even more urgent and important.
This has been really, really insightful. A deep dive into a risk factor that maybe hasn't gotten as much attention as it deserves, especially regarding early heart disease. So to sum up, this huge meta-analysis gives us really strong evidence that high LPA is a crucial independent risk factor for premature ASCVD, particularly for coronary artery disease and peripheral artery disease in younger people.
And it really shines a spotlight on those specific groups, people with South Asian or Caucasian descent, those with familial hypercholesterolemia or type 2 diabetes, and crucially, individuals who also have higher levels of standard LDL cholesterol. For these groups, this genetic risk factor seems like an even more powerful predictor of problems happening early in life.
And like all good research, the authors acknowledge some limitations, right? Things like potential differences between the studies they included, maybe limited data on certain subgroups like people with extremely high LPA or other ethnicities.
Yes, and some variability in the results for very specific analyses, like that top quintile finding we discussed, standard stuff in meta-analyses. But despite those nuances, the overall signal coming from data on over 100,000 people is pretty compelling.
Yeah, the weight of that evidence really helps clarify the picture for younger populations in a significant way.
It definitely strengthens the case for LPA being an important player in premature disease.
So let's leave you, our listener, with this final thought to mull over. Given that your LPA level is mostly set at birth, it's genetic, and it can silently contribute to your heart risk for decades before any symptoms might show up. How does knowing about this specific risk factor, or even just the potential for having elevated LPA, either in yourself or someone you care about, how does that change the conversation you have about preventative health, about testing, maybe starting today?
Yeah, it kind of shifts the focus, doesn't it? From just thinking about risks you develop over time to understanding a foundational risk you might have had all along and thinking about how that knowledge might influence your proactive health choices, starting now rather than later.
A really important perspective shift. That's it for this deep dive. Thank you so much for joining us.
And look, if anything we discussed today raises concerns or questions for you personally, we really do encourage you to explore this topic further. Talk about your own risk factors, including potentially getting your LPA checked, with qualified healthcare professionals. They can give you advice that's tailored specifically to your situation.